Good evening to the Smile Coast, west coast of Africa, and other attendees. We're here today to talk about liver imaging and some very specific aspects of liver imaging, specifically the key role of vibration-controlled transient elastography in staging liver disease and establishing a role in clinical care pathways, following published information, following guidelines, and really talk about how to use this in your practice, including surveillance for your patients, your practice, and your organization. I'm Robert Gish. I'm a hepatologist based in San Diego. Brenda Ivan is our administrator, who you have heard a lot from through email and WhatsApp. Brenda, thank you so much for all of your work. I also want to thank the High Sky team that's here, Fiona, Reed, and Stan, who helped support this event today. Just to remind you, today's event is in English. Tomorrow morning, same time, different link, we'll have a French presentation where Stan will be our host and Dr. Tariq Asala from Paris, France, will be presenting a presentation in French with French language slides also. As far as we can tell, first of its kind to have this dual presentation approach. This will be recorded, this will be posted, the slides will be shared, and we are in great status right now. We have 3 short presentations and then time for a Q&A. We should finish by the top of the hour. Thank you so much. I think people on this call are very familiar with the prevalence of hepatitis B and C globally, regionally, and hopefully also within your specific country. There is just a new release of hepatitis B epidemiology specifically, and also hepatitis C epidemiology from the CDA group, the Polaris Institute, based in Colorado, but who has a contract with WHO and a contract with many countries. There has been a small decline in hepatitis B prevalence, a combination of vaccination, treatment, and sadly, people passing from cirrhosis, end-stage liver disease, and cancer. We're trying to bend that curve, and we'll be talking about ways to bend that curve with our different tools, including liver imaging, specifically liver stiffness and staging liver disease, and allocating patients to different care pathways. This still is a major global crisis. Top 10 causes of death worldwide. Number 1 cancer in terms of cancer mortality is hepatocellular carcinoma, often because of very late diagnosis and lack of treatment resources in many countries. And the majority of individuals, specifically with hepatitis B, are undiagnosed and even more, sadly, untreated. Hepatitis C is a ways ahead. Diagnosis is much higher. Treatment is higher, especially because we have a curative therapy for hepatitis C. But with hepatitis B, we have very low-cost medications with very few side effects, essentially no resistance, and can decrease the risk of liver failure by 90 to 99% and can decrease the risk of liver cancer by 70 to 90%. So it's time to test everybody and link all individuals to care. Care pathway is treatment, and care pathway is vaccination for those who've never been exposed. So to reach HBV elimination and hepatitis C elimination targets, you have to have diagnosis and treatment at very, very high levels, and we are far behind on a global basis. There's a number of countries that are meeting those elimination guidelines, but that number is approximately 12 countries right now. in the world, and we have about 190 countries that need to reach these very, very important goals. To do this, of course, including decreasing mortality rate, is appropriate staging of liver disease and instituting more aggressive care pathways in those individuals with more advanced liver disease. Fatty liver, the third part of liver disease that we're going to talk about today, and of course, the fourth pillar on the temple, on the chair, on the table, is alcohol-associated liver disease. And fatty liver disease throughout the world, including Africa, is on the rise. This is giving you prevalence data, and NAFLD here is at the height. Alcohol-associated liver disease is also increasing in both men and women. It's interesting that they have drug-induced liver disease on here for the first time. That's that short yellow stroke that's here. And of course, progression of fatty liver disease can be maintained and monitored with proper testing, retesting, and surveillance, but also this helps us with intervention. Liver fibrosis is the key for staging every individual. Once you've diagnosed some type of liver disease, staging is absolutely essential, and this helps allocate patients to different care pathways. Patients have very, very mild fibrosis. They require less resources, less monitoring, less laboratory, less clinic visits. Those with more advanced disease, especially those with cirrhosis, need ongoing surveillance for liver cancer. Ultrasound and alpha-fetoprotein still remain at the front of that surveillance strategy. Remember, screening is the first test, surveillance is the second test. Even though biopsy is the gold standard, and I'll call this the silvered standard, this is not standard of care in the setting of alcohol, fatty liver, hepatitis B, or hepatitis C. It's expensive, there's sampling errors, and I'm going to move quickly because liver biopsy in most forms of liver disease has been replaced by our staging tools. Serologic tests are also available to, of course, diagnose, but here we'll talk about serologic testing for staging disease. This can be something as simple as the APRI score or FIB4, which can be performed in the $10 to $20 range. More advanced testing such as ELF testing, FiberSure, or FiberTest often costs in the hundreds of dollars range. And it's nice to be able to have in development now point of care tests for platelets and liver enzymes that may bring down the cost of tests such as FIB4 or APRI in the very near future. Ultrasound does help you also to stage. It gives hints about fibrosis and fatty change. You can measure the spleen size and portal vein diameter. Those are definitely quantifiable on ultrasound, and I strongly recommend that you measure spleen diameter and spleen size in every patient. VCTE has been a huge advance, been available for now about 2 decades in some parts of the world and less time in other parts. But this really allows us to screen and diagnose the stage of liver disease. This doesn't diagnose hepatitis B, C, fatty liver, or alcohol, of course. That's through medical history and laboratory testing. But staging is part of that assessment of every patient. And as I mentioned before, is a key part of allocating patients to different pathways, treatment pathways. This is a probe that generates a sound signal, and the timing of the return of that sound signal gives you a stiffness reading. Stiff tissue has a higher sound transmission rate, whereas soft tissue has a slower sound transmission rate. And this has been standardized, and research has taken place over the last few decades to really bring this to the forefront. And it's easy technically, it's a simple probe. Many devices, including the HiSky device, the iLive Touch, which I'm most familiar with, has an ultrasound device that helps you target where the best quality imaging is present. And you have a combination assessment with ultrasound for targeting or potentially evaluating the liver in general, and also making sure that you have the right position for your probe. This is the vital sign of the liver. You're going to get blood pressure, pulse, respiratory rate, temperature on all of your patients in clinic. And now, if you have a liver patient, determining liver stiffness and also attenuation scores, which I'll add in as the second main tool on these devices to calculate the fat level in a patient through an attenuation number specifically. A little bit more on this attenuation parameter, on how this ultrasound type wave, sound wave, goes into the liver and attenuated by the level of fat that's present. These attenuation parameters, UAP here, that's the abbreviation we're going to use, quantifies liver steatosis and closely parallels what you can find on biopsy or what you find on MRI. PDFF is another example. And this also gives you guidance on how to intervene with your patient. So, liver fibrosis, liver fat quantification is an essential part of assessing your patient in combination with physical examination and laboratory testing. This device, once the device is purchased and in place, is a very low maintenance device, can be used for assessing thousands of patients, requiring very rare intermittent recalibration. And the device is also meant to be used in a variety of clinical settings that also indicates the stability of the device in clinic settings and public screening events, etc. A little bit more here. This, of course, is painless, although the individual does feel a slight tapping sensation. Accuracy has been well defined in the literature. And the devices from HiSky have over 300 publications utilizing their technology in different clinical settings and research settings. And this is vibration control transient elastography is listed in a variety of different guidelines. And interesting, this technology is being reviewed in the US by the US FDA as a potential replacement for liver biopsy in clinical trials, which I think is fascinating because if we had to replace liver biopsy in clinical trials could move forward in a much more, variable situation. Okay. This just gives some information here on hepatitis B, deciding on treatment, follow-up efficacy, assessing prognosis. My typical pattern for monitoring patients is to be doing this elastography and attenuation assessment annually. But if I'm intervening with some type of therapy and I see a therapeutic response by laboratory testing, or I want to assess a therapeutic response, I would be doing that on a 6-month cycle. So that completes part one of our presentation. I am going to now move to our second slide deck. As we move through this, looks like we have a number of attendees here, so this is going well. Let me know, Brenda and HiSky team, if there's anything else I need to do. I don't see any open questions in the Q&A. And I am now opening my second deck. And are you able to see slide number 2? Everything okay? All right. A little bit more about the device. This is the iLive Touch, an integrated device, and gives you high definition ultrasound here in the central box. The quantitative fibrosis degree, liver stiffness value is demonstrated here. And you also are going to be getting values, including the quality of the image through something called the IQR definition. On the far right, you're seeing a quantitative steatosis degree, which is that UAP value that we described previously. This is a larger device here. There's a smaller device that has very similar access points, and that can be carried in a small suitcase the size of a carry-on that can be mobilized with wheels and a handle. This is the certification from different parts of the world. We have China, US, EU, Russia, Australia, Korea, and Japan, showing this has met the highest level of standards from these certification authorities. HiSky has a variety of ongoing research and development efforts in transient elastography technology. This is designed for patients who are thin or thick, large. PANIS really allows you to get through the amount of tissue that may interfere with the utilization of other smaller or earlier developed probes. This just gives you more information, including multi-channel tissue information scanning and a sample volume of 30 cubic centimeters, about 1,000 times larger than a liver biopsy in that sample volume. Technical advantages are listed here. Broadband dynamic technology. There's a patented algorithm. Of course, the magic word AI always comes into this in terms of what your computer is doing for image processing to give you high quality information. This is what a report looks like. In this example, individual liver stiffness measurement was 5.7 kPa. So this is going to be an F0, F1. Attenuation score here is 223. I always remember 220 is normal and 330 as severe. And of course, gradations there. And it gives you these liver stiffness measurements in terms of the different potential F scores and the level of fat severity on this. So very, very nice, simple output. They've got heights and weight here. You've got your BMI calculation, gender, and age noted in the upper part of this readout. Give you a little bit more information. Things do move a little bit depending on what your liver disease is. So for fatty liver, you've got the upper score, alcohol-associated liver disease. You may have a cutoff at 15 instead of 20. One of the reasons for this is that attenuation, the higher the fat content, has a tendency to overread liver stiffness. So there's a correction factor that goes into this, establishing these ranges in different patient populations, including hepatitis B with normal ALT and abnormal ALT. So the higher the ALT, that may result in an overread of liver stiffness. And there's here what I call a correction that's present. And hepatitis C values at the lower end. So this is covering the 4 major forms of liver disease. There's a reference chart available, and in the far right column, it gives you an approximal parenchymal calculation for fat. Clinical studies and publications across a variety of even more rare conditions such as autoimmune liver disease. There's data in the pediatric population. I think you can even have more complex patients. You may have co-infection with different viral diseases, and useful in the liver transplant and general population statistics as well. More clinical studies. You've got utilization. Oh, I don't know why that went forward. Let's see if I can go back. Over 5 million adults in China, utilization data, clinical study for hepatitis C with Gilead, multi-center study in the US is ongoing, led, I believe, by Dr. Calvin Pan. So other data is ongoing in China and Italy. So there's still research in progress. Very encouraging. And this is where transient elastography has been listed in different guidelines. And of course, the slides and all this data will be available offline after this presentation. If you need more information, the recommendation level is high, designated on the right side here. Listed here in the MMWR, the CDC documentation, and talking about screening individuals and also staging liver disease has been mentioned there. This is a very nice evaluation here. It's going to be a list of what you do when you're in clinic, of your history, your physical exam, patient education, routine laboratory testing, serologic assessments, virologic assessments, and abdominal imaging. So every patient I see with liver disease gets a full abdominal ultrasound. I get baseline liver cancer risk scores. I do a triple panel with AFP, L3, and DCP, as well as AFP. Then elastography is listed here. This can be used in combination with FiberSure, but I'm much more likely to use this with Fib4 since Fib4 is almost free once you've done your basic laboratory assessment with chemistries, including liver enzymes. This is an algorithm for assessment and monitoring of chronic hepatitis B patients, and they list here APRI score. And now it says detection of HCC. I'm going to call it detection of risk for HCC. To do your detection profile, you would need an full abdominal ultrasound technology, of course, and combine that with your patient's liver cancer risk biomarkers, preferably the liver cancer triple panel, but AFP is in great shape also. Very useful. Regular assessment of liver fibrosis has been listed here in the WHO, and APRI and transient elastography in a frontline position. And one set of guidelines, which will be released in the next few weeks, are the APASL hepatitis B guidelines. And if you're on our listserv, we'll send you a copy. Hopefully, you've already received in your inbox a slide deck in PDF format. And they're taking the treat all approach in the new Asia Pacific guidelines, and non-invasive testing, including elastography, is in a frontline position for staging patients that may help you prioritize if you have limited resources. A little bit more information here from the China guidelines and the algorithm that's present. This non-invasive technology is advised on a 6 to 12-month cycle. I typically do this on a 12-month cycle, but 6 months would be considered if I have very active interventions. So that's part 2 of our presentation. I'm now going to go to part 3. I'm going to stop share just for a moment and thank everybody for attending this. Need to get back to share screen and find our third presentation. Give me just one more second. And going to full screen. Here we go. Excellent. Okay, so we're going to do a case demonstration and a few special settings where vibration-controlled elastography can be a key part of your practice. This is a picture of somebody that I knew before he passed away in 1988. That's right when I started my hepatology career. Dr. Popper was at all of the AASLD meetings, and I saw him actually initially in 1984 in Chicago at the Marriott, where AASLD had its birthplace, and made this statement that anyone who can stop or delay liver fibrosis, he used the word cure most chronic liver disease, but I'm going to use the word treat most chronic liver diseases. And this staging allows you to allocate resources and triage patients for the best care possible. This is just talking about comparing transient elastography, liver stiffness measurement, and comparing that to liver biopsy. This is one of the key questions that came in prior to the meeting. The people sent in their pre-questions. This is over 400 patients with hepatitis B. Liver biopsy data was available. A number of these researchers, including Professor Jia, who's the senior author here, we're very familiar with, and Dr. Hong Yu, third to last author on this, is the lead author on the APASL guidelines, and she was also the lead author on the China guidelines that came out in 2022 for hepatitis B. And you can see in the right box that the AROC curve is well over 0.8, giving you a high level of confidence that when you measure liver stiffness, that you are measuring an accurate level of liver damage and liver fibrosis in that patient. I always make this statement that I never use just one test. I don't depend completely on liver stiffness measurement. And as you can find in many algorithms, including the AGA and AASLD algorithms for managing fatty liver, for example, is using liver stiffness in combination with the Fib4. Success rate, very, very high in this population, 99%. In my clinical practice, liver stiffness success rate runs around 90%. So you have to have a backup plan if you have a 1 in 10 patient. My experience, usually very, very obese patients or very, very tiny patients, which we often see in the Asian patients with very small rib interspaces. But success rates are quite high with this. And I've had multiple hands-on experience where I was using the iLive Touch device, and I had a very high success rate in a variety of individuals, both with different forms of liver disease and also using it in normal patients as I was being trained on the tool itself. So, what about evaluating the effect, the efficacy, the treatment success of antiviral therapy? So, you can use this to follow-up detection methods as people get treated, enzymes normalize, liver fibrosis reverses, liver health improves. That fibrosis improvement can follow in downstage patients from F4, F3, F2, even down to F1. And I think this really helps with patient compliance. Of course, they like to see their hepatitis B DNA level decrease or become undetectable. We like to see their liver enzymes improve. They have abnormal liver function, such as bilirubin. We follow bilirubin as a liver function test, of course. And just to remind you here that LFTs is a term we're not using at this time. We describe either liver enzymes and we spell out liver enzymes, and we're talking about AST, ALT, ALK Phos, and GGT. Those are the 4 pillars of liver enzyme assessment. And liver function indicates bilirubin, albumin, coagulation tests, which usually don't become abnormal until very late. And now my 4th pillar of the liver function is a direct bilirubin, or occasionally the 5th pillar, I do quantitative bile acids as a special tool in cholestatic liver disease. So this is a tool to be used in combination, this liver stiffness tool itself. This is an interesting document and research, which I, quite frankly, before we set up this call and this presentation, I didn't know about using this in this special setting. These are patients with hepatitis B. They had hepatocellular carcinoma. They were undergoing a surgical procedure. They underwent detailed preoperative assessment, and that included liver stiffness measurement. And this was monitored for post-operative liver failure, monitoring, of course, liver function and presence of ascites or encephalopathy. This is quite interesting that in the cirrhotic patients only, that risk of post-hepatectomy liver failure was a cutoff of 17. Predicting the presence of cirrhosis was 12. It's interesting that some of those cirrhosis patients, of course, could tolerate the surgical resection. So this is a new tool that can help surgeons. Now, of course, they're going to look at platelet count, and they're going to look at bilirubin, or you may look at bilirubin, you may look at platelet count, and use that in combination with this liver stiffness. If you have a patient who potentially is marginal for hepatectomy, and this really does help you complete informed consent. You really do want to give that patient the most information before they consent to a surgical procedure. So this is just going into a patient, 45 years of age, a woman, known hepatitis B, surface antigen positive by a point of care test. And that was confirmed by a commercial assay. That's an important discussion in Africa because some of the point of care tests have a high false positive rate. And of course, we're on the hunt for quality point of care tests for our collaborators in Africa and around the world. CBC count was abnormal because the platelet count was 120,000. That's definitely going to be giving you a number that's going to suggest advanced fibrosis and probably cirrhosis. CAP score intermediate range here at 290. So the question is, how do you manage this patient? This person has what I call MET HBV, combination metabolic disease, and hepatitis B. Liver enzymes are high, ALT higher than AST, so that's going to support this person is probably fibrosis level 3. Liver function is good with a total bilirubin of 0.6, so that's excellent news for that patient in terms of liver reserve. CBC is normal except for the low platelet count, cholesterol high. That's a whole other discussion about managing hyperlipidemia in patients with metabolic syndrome. No evidence of renal dysfunction and normal urinalysis, normal serum electrolytes. So this person, if they were cirrhotic, MELD score would be low. MELD 3.0 score would be low. Now, patient undergoes VCTE, liver stiffness, as you can see here, 13 kPa. That's going to put that person right at that edge of F3, F4, especially because they have a combination of hepatitis B and fatty liver. So I'm going to probably describe F3 to F4 for that individual. And that fat score here, it was a little bit lower at 258, but still indicating a significant fatty level that's here as well. The IQR here at 1% indicates a really high quality image. And of course, you're going to be thinking about what to do next. And people with hepatitis B and fatty liver, that's a strong indication to treat immediately and at any level of HBV DNA. After treatment, now liver-related treatment, of course, would focus on combination of hepatitis B and fatty liver. And over time here, we have a decrease in liver stiffness measurement. Fatty liver hadn't changed a lot. UAP score here at 251. But this is really going to encourage ongoing management and clear reversal of liver disease. I think this is very useful and very helpful also. So that's a wrap up on a couple of very important issues. One is this issue about preoperative assessment. And also we have a case report and helping you manage, guide your patient and do follow-up. I want to thank the High Sky team. I want to thank Brenda. I want to thank all of our attendees that are on this call. And many of you will be listening to this later. Also, this will be recording, which will be posted and shared across our web services, our WeChat, our social media, WhatsApp. And we'll make sure that everybody gets included in sharing this and share out further to your colleagues and, of course, your professional associates. Thanks again for joining us, and I think we now have some time for Q&A. So somebody was asking about what two methods I use, and I'll go a little bit further. My top two are using Transient Elastography and Fib4. I think Fib4 is more accurate than APRI score, although Fib4, Dr. Asala, does have a challenge because it overestimates fibrosis once the individual's over 60, 65 years of age. There's a new version of Fib4 that corrects for that age overestimate. I look directly at the platelet count. So the platelet count 170 and above is probably no major fibrosis, no advanced fibrosis. Between 170 and 120 is going to be fibrosis level 3. Below 120 is going to be fibrosis level 4. I look at the AST to ALT ratio. That's also free once you've gotten your chemistry panel and your CBC with platelet count. So the only other costly tool to stage liver disease is measuring spleen size and portal vein diameter to get a full abdominal ultrasound. But on the iLive Touch, there is a full abdominal ultrasound device probe, so you can actually use that not just to target your liver sampling with your VCTE device, but you can also use that to measure specific anatomical issues. Though the specific conditions that FibroScan will report are going to be liver stiffness, and they're going to give you this attenuation score. In terms of the diagnosis, that needs to be made using standard laboratory testing and your serologic tests for hepatitis A, B, for hepatitis B and C, also for fatty liver, and alcohol is going to be alcohol history. There's now a blood test for alcohol exposure called PEth testing, and that's something that we're actually actively bringing to China right now. It's available extensively in North America and Europe. PETH testing will tell you how much alcohol somebody consumed over the last 30 days. So let's move here. How does the use of vibration-controlled transient elastography influence clinical decision-making? I think the most important issue is with more advanced stage of disease, you're more likely to intervene to treat something like hepatitis B if you have limited resources, limited access to, say, tenofovir or entecavir. People have more advanced liver disease, metabolic syndrome. You're going to be more aggressive managing that metabolic syndrome. And if you have access to medications such as GLP-1s or resmetirom, you'd be more likely to intervene with pharmacologic therapy. Now, scrolling down, when you use transient elastography, how do you make sure that the results are correct? Most importantly is look at that IQR score. That's going to be giving you consistency across multiple sampling. Also, you can make sure that you are having a high quality image when you're in the rib interspace. There's quality tools within the imaging criteria to determine that you're looking at the correct imaging. And to get expertise, I think Dr. Osla brought up a very important question that, in my experience, between 20 and 50 exams supervised, that person, that technician, that medical person can then move forward. Excuse me, can then move forward and be operating as an independent individual, always having a backup though with a specialist available would also be quite good. There are people who can reverse liver disease from hepatitis B with full viral suppression. The collagen deposition in the liver is very much a dynamic approach. That dynamic is building collagen and degrading or reabsorbing collagen. As you suppress hepatitis B, take HBV DNA to undetectable, and typically in parallel, liver enzymes improve. Those individuals have that opportunity for reabsorbing collagen deposition and reversing fibrosis. So even early cirrhosis can be reversed, and patients can be downstage through stage 3, 2, and 1. I've had some patients go all the way back to normal. I've had also that happen in patients who I treat with resmetirom or GLP-1 agonists, and those individuals can also reverse their liver disease. I've had some patients on therapy, typically in combination with weight loss, whose FAT score went to less than 220 and their kPa value went to less than 5.1, indicating complete normalization of that patient's liver health. So I think it's super important for experience, very important for image quality, very important to be using this ultrasound device to target the correct location. IQR, in my opinion, needs to be less than 20% to indicate consistency across imaging, as those imaging numbers are averaged, and reproducibility of the shear wave imaging is, again, going to be monitored by image quality and that IQR result. So the shear wave elastography is a different device. That's another question that came in. There are multiple types of shear wave. There's point shear wave, 2D shear wave, and even what's called three-dimensional shear wave. And this requires a different sound signal and different levels of imaging processing. There are companies that are in this space that use shear wave technology, and this is a different tool than VCTE. The data on shear wave is, I would say, much less robust, and also there are shear wave technologies that are attached to devices from companies such as GE, Philips, and Siemens. Those also have much less data published. So, in the world of publications and academic institutions, vibration controlled transient elastography has thousands of publications that are out there. The company FibroScan had led the way in this space, but as I mentioned already, there's in excess of 300 publications using the high sky VCTE technology. So I think that can give you great confidence in this device and utilization in this setting. So I'm going to switch over to Stan to help us. Stan Dembinski is a person I've known for over 20 years who is an expert in this imaging space. Stan, can you help me with some of my answers? Am I going down the right pathway?
I had a question for you from a very global perspective. Imagine that I'm a doctor who has been treating hepatitis patients for a while, but without the help of transient elastography. Um, can you help me understand what will be the impact on my practice? What will be the impact on my patients, on their outcomes, on the way I will be treating them if I get the transient elastography technology in my daily practice?
Great question, Stan. We know that whatever tool we use, we have an error rate of 20 to 30% potentially. This goes for FIB4, APRI score, platelet count. And when you're talking about a patient's health, a patient's life, you want an accuracy that's not 70 or 80%. You want an accuracy that's 99%. Patients want to know where they are. They want to know the stage of their liver disease. They want to know, do they have cancer? They want to know their prognosis. They're coming to us as medical specialists to help determine their future. They want to plan their life, their family life, their personal life, their work, many other factors. So by adding liver imaging, and most importantly, in this case, liver imaging determining liver stiffness and the presence or absence and the level of fat in the liver, you can give your patient an extremely high level of confidence in terms of that prognosis. And just think, we're going to reassess people with a physical exam, laboratory, symptoms, and imaging on a approximate 12-month cycle, although I tend to see patients every 6 months, laboratory tests every 3 months. Now you can follow those individuals and you can allocate them if needed for surgery if they develop cancer. And finally, staging patients helps you determine who should be undergoing long-term surveillance for things such as liver cancer. What's their risk for liver cancer? There is a connection between liver stiffness and risk for liver cancer in the future. So we all want to be accurate. We want to be focused. We want to really help our patients determine their life pathway, and this helps immensely. Stan, I hope that covers everything.
Thank you very much, Bob. I have a follow-on question. Uh, some patients have a very good adherence to recommendations and come back very often. Other patients might need a bit more encouragement or evidence to help encourage the return. Um, do you have any comment with regards to how this uh, VCTE physical measurements can impact the relationship with the patient and creating a stronger return rate?
Fantastic question. I know where you're going with this. It's absolutely true. By sitting there next to the patient with an imaging device, looking into their body with basically a sound camera, and the patient can see, and they often look at that image that's on that screen. You can now talk to the patient about what's inside their body. When you're talking to a patient about a laboratory test, it becomes very, call it abstract. It's not necessarily a direct connection. When you've got a picture, an ultrasound picture, or that imaging, that's the image that's generated by the vibration controlled elastography, you connect with that patient on a professional level and give them motivation to come back because they believe that you are an even better clinician because you have this tool and you have this accurate tool that helps guide them on their life pathway.
Thank you, Bob. Unless someone has another question, I have another question.
The only thing that popped up is cost, and I think that cost has to go back to Reed and team and you and Fiona to get back to the different countries. So I think there's a way to answer that directly through the chat and the connecting with the High Sky company. I guess, do you call it High Sky or Hisky?
Hi, Sky.
Okay. I've heard other people pronounce it other ways. Back to you, Stan. Next question.
So next question is, we see then that having a complete set of tools can potentiate, improve the amount of impact that you have on your patient group. Now, as you do that, you might expect that word of mouth will increase your patient recruitment, your patient catchment area. Any comments with regards to how this tool helps you be more efficient, have a faster throughput, and be more precise on where you need to spend your energy, your time?
So, on a more global basis or regional basis, if you are going into a community and doing screening for liver disease, telling patients that you have the ability of this imaging device there, I think is a marketing, which is important for all of us, marketing your team to come into an area to determine liver disease or liver health. And I'll give you an example, Stan. I know you were in Amsterdam for EASL last year, and the EASL team set up these imaging booths in these little houses. And every day there were thousands of people lined up to look into their liver with these imaging devices to determine their liver disease or liver health. I was amazed. There were people who would wait 2 or 3, 4 hours to have a picture of their liver and determine liver disease or liver health. So I think that's an important issue. Then on an individual basis, of course, accurately determining who needs to come in for follow-up on a 6, 3, 12-month cycle, maybe not come back at all. I've had some patients have used this to determine no liver disease. You don't need to return unless something changes with your laboratory tests. So on an individual basis, it really also helps with accuracy and confidence. Your patients, your community, because some of these people aren't patients yet, they're just getting screened, want to have the highest level of confidence. And that's where this liver imaging combination of liver stiffness and this attenuation fat score really helps. I find it to be groundbreaking. It's like flying an airplane without radar. This is flying an airplane with radar, so I can see where I'm going.
Thank you, Bob.
A couple more questions just came up. We have just a few more minutes. There's a question about micronodules and why they don't disappear in some cases. So, fibrosis can be reversible or not reversible. And the more advanced the liver disease, the more mature the collagen is in the liver, the less it can be reversed. And in the old days, when we were doing biopsies and had trichrome stains with that beautiful blue color, it's not beautiful if you're the patient, of course. Dark blue, advanced collagen, those patients rarely reversed. Very light blue, very thin threads of collagen, there also would be a chance for reversal. So I think that's an important issue. And there have been correlations with liver pathology with these devices. So that I think is super important. There's another question about a device called Hepatus. Hepatus is a device that has a different way of measuring liver stiffness. I believe Hepatis is the machine made by a company called Mindray, and that uses the shear wave technology as opposed to vibration controlled. We don't have any head-to-head study with the High Sky I Live Touch and Hepatis, and this is a device that is available, but I can't tell you other than technologically how they differ. We don't have head-to-head information about comparison with I Live Touch. Brenda, anything else?
There's another question there. Last one.
Yeah, I think the last one was from Dr. Asala. Two methods we chatted about: transient elastography and Fib4. We think we covered that in clinical practice, guideline recommended cutoff values. I'm going to say guidelines are guidelines. One of the questions here is about how strictly you follow those cutoffs. And I'm going to say take into account the CAP score. If the CAP score is 400, it's likely that the elastography score is going to overestimate the level of liver fibrosis that's there. If the spleen is 15 centimeters in size, that person has portal hypertension. They've got advanced fibrosis. If the platelet count is 90,000, they have advanced fibrosis. So don't depend on any one test. Look at this in combination and decide after you look at all these what that patient's stage of liver disease is. I really trust the CAP score because we really don't have another way of measuring liver fat unless you're doing MRI, PDFF, which is expensive and available in very few locations. So the CAP score tends to be quite accurate. I'm going to say 95, 98% accurate. The liver stiffness measurement, I'm going to state 80 to 90% accurate. And with the liver stiffness, you're going to look at more things: platelet count, Fib4, spleen size, portal vein diameter, if you have that available. And then decide. We have intelligence in our brain. It's not artificial, it's real intelligence. You can put those pieces together and decide where your patient staging is. Brenda, I think we answered all the questions. We've got a couple more minutes to wrap things up. Stan, any follow-up comments? Thank you very much for hosting our French version tomorrow. I do want to market that, of course, with you and Dr. Asala.
I have another quick question, maybe, if we have time for that, Bob.
I'm ready.
One of your first slides showed the oncoming fatty liver epidemic, MASLD. And MASLD evolves obviously towards MASH, where fatty liver creates stiffness in the liver. How important do you think getting baseline readings on the stiffness before MAFLD advances too much in order to be able to know what the control level for a specific patient is? How would that be important for you in your following a patient?
You're bringing forward, Stan, something that's super important and that's happening in the general community. How often, how early, who should be tested for fatty liver? Do we just go out and test everybody with liver enzymes? Do we go out and do liver imaging on 100 million people? And my threshold is anybody with diabetes needs to have baseline liver imaging, plus, of course, the laboratory test that we talked about. So I have very simple thresholds. The other threshold is BMI over 30. I think every individual needs baseline lab tests and liver imaging. So I'm going to give you two simple parameters: diabetes, high BMI. And of course, once somebody has metabolic syndrome and elevated liver enzymes, those individuals should have a baseline value also. We know that if you have 100 people with fatty liver, less than 15 out of 100 are going to progress to advanced fibrosis and cirrhosis. 15% is the number I use. Other people, high risk of heart disease, high risk of stroke, high risk of various types of cancer. And we know that liver stiffness helps predict not just MALO, major adverse liver outcomes, but also helps predict MACE, major adverse cardiovascular events. So liver stiffness, like the liver enzyme GGT, can predict cardiac events.
Thank you, Bob.
Should we do a final marketing for tomorrow morning? Same start time, 8 a.m. where I am in California. Tariq, thanks for joining us today and your questions. Stan, you're wonderful. I'm seeing Zaniel on here. Reed, you're wonderful. Fiona, thanks so much. Really want to thank the High Sky team for supporting these two events, first of their kind as far as we know in Africa. Thanks everybody on the Smile Coast and helping us. Brenda, thanks for helping organize this. You're a maestra, la maestra, the teacher, the professor, for helping us. Thanks everybody. We'll see you tomorrow morning.